All right. I can see it's 1 minute after the hour, and I want to get started. We have a lot of material to cover today, so I want to welcome all of you again to this Privacy Value Set webinar presentation that is being supported by a number of organizations: Clinical Architecture, CRISP, Health Gorilla, the National Association of Community Health Centers, as well as Planned Parenthood of California. So these are going to be our speakers today. My name is Stephen Lane. I'm the Chief Medical Officer at Health Gorilla, and I've been working in this area for quite some time. I'm joined today by Dr. Victor Lee from Clinical Architecture, Lisa Matsubara, who is an attorney and Chief Legal and Advocacy Officer at Planned Parenthood, Nicole Sweeney, another privacy expert from CRISP in Maryland, and Dr. Raymond Uy, another clinical informaticist who works at NAC. So I really thank all of you for joining us today to cover this important material. So I'm going to go ahead and set the stage here for us and talk a bit about this important area. We do have the Q&A open for all of you to submit questions. We'll be capturing those questions over the course of the presentation, and then we will be trying to address those at the end, time allowing. So I think we're all aware that there have been long-standing restrictions and protections around health data, supported by both federal and state laws, many of these going back to the days of paper medical records, and many of them not completely updated to address the challenges of digital data and the advancements in interoperability. Variable implementations have been made to try to protect this data, lots of different workflows, not a lot of standards. But I think it's important to realize that there is a tremendous amount of health data that is out there, and it's defined in various ways by various statutes. You know, when you can think of this largest circle here regarding all of the health data that are all the information that impacts our health, whether it's from wearables, from electronic health records, you know, from payer systems, et cetera, et cetera. And then there's a subset of that world of data, which is considered protected health information. You know, under HIPAA, this is data that's created by a provider or a payer. And then there's that subset of that, which is in the electronic health record. It can either be as coded discrete data, it can be as free text notes, it can be as scanned documents, but there again, it's a subset. And at the end of the day, there is a set of codified data, which are the specific codes related to procedures, diagnoses, medications, test results, et cetera. And that is really the area that we're going to be focusing in on today, is that codified data. So there have been a number of recent federal actions that I'm sure most of you are well aware of. The Cures Act final rule, which defined and prohibited information blocking, except in certain circumstances where an exception applies. In June of 2022, the US Supreme Court decision in Dobbs v. Jackson Women's Health really changed this landscape. As I said, a lot of these rules have existed for a long time, but suddenly there was a real pushing force here to really get us to pay attention, especially to abortion-related data and how the exchange of that data between different entities and across state lines could have really unintended consequences. So that really lit a fire under a number of us to move forward. And then just recently, just last month, the OCR gave us a final rule around HIPAA support for the privacy of reproductive health care data. So we're going to talk about all of these, as well as a number of state laws that have been passed, again, since the Dobbs decision, in an effort to assure the privacy of particularly reproductive health data. So Maryland was out in front here with their Senate Bill 786, which really looked very specifically at abortion care and reproductive health services. And the thing about this law, which is unique, is that it really focused in on codified data, that inner circle that I was showing you earlier, specific to diagnoses, diagnosis-related groups, CPT procedures, medications, And this law has been on the books for a little while now. The compliance date was deferred until I guess a couple of weeks out from now. And Nicole Sweeney from Maryland has been very much involved in this and will be diving into this. In California, we have the Assembly Bill 352 that Lisa was very involved in driving forward. This has a slightly broader scope. It looks at data related to gender-affirming care, abortion, and related services, as well as contraception. The focus here is on assuring that there's specific authorization when this data is released out of state. Here again, compliance is already in flight for certain aspects of this one. The difference here in California is that there is a reference to the types of care, but not a specified list of data elements, specific codes that it covers. So the approach to compliance with this is going to be somewhat different than in the case of the Maryland law. I think most of us are probably aware of the HIPAA privacy rule to support reproductive health care privacy that came out last month. I think a lot of us, actually, a lot of this work was supported, by the way, by AHIMA, the American Health Information Management Association, which is really interested in assuring that this data is managed appropriately nationwide. We started down the path of developing value sets to support this, but the way this final rule came out is it's really even less specific to the codified data than the California law. It's really a purpose-based restriction that prohibits the use and disclosure of PHI when it's sought for specific purposes. And those prohibited purposes are listed here, 1 through 4. But it's complicated because it's not always completely clear for what purpose data is being requested. I've personally set up connections to exchange data with medical examiners, and that data was requested under the treatment purpose. So we have some challenge in terms of how we're going to support and comply with this purpose-based restriction. So probably a number of entities are going to look to value sets to try to identify the relevant data to support their compliance with this rule. The definition of reproductive health data under the new HIPAA rule is really quite broad. It's really all healthcare that affects the health of individuals in any matters related to the reproductive system. It's not restricted by gender, by age, by procedures, et cetera. And while the preamble of the rule gave a number of very specific classes or areas of data that would be included, this is not all inclusive. So you'll hear about efforts that are going on to create and provide value sets for all of these areas, but it's important to realize that because this is a purpose-based rule, that this will not be a comprehensive solution in the way that potentially in Maryland we can do that because of the codes being specified in the law itself. So we're here to talk about value sets that have been developed and made available publicly to support compliance efforts. So these are explicit lists of codes, which identifies the data that needs to be managed differentially. And again, the initial focus has been on diagnoses, procedures, medications, documentation, realizing that there are sometimes multiple code sets that can be used to define that data. These value sets can be used to identify and tag the codified data that is maintained or exchanged, but can also be used to go looking for relevant data that is in unstructured fields, the text, the scanned documents, et cetera. I think that's going to be a second phase of this work, and the value sets are initially going to be used to be looking at codified data. Once you can find this data, it can be segmented. You know, segmentation is an interesting term because it sort of sounds like you've got paper records that are in 2 different cabinets. But of course, when you've got a unified health record or database, that's harder to do. But the idea is that you can identify this data and manage it differentially as needed. And again, there are varying applicability to compliance efforts. Maryland's law, relatively straightforward. California's law, a little bit trickier. And the HIPAA rule, as I said, is going to involve a multi-layered approach. So we're talking about segmenting the data, first to identify it, to be able to report on it, to tag it, and to create rules and enforcement mechanisms. And then we're also, and we're not going to focus in on this today, thinking about consent management. Where is consent required? What is the content of the consent, the format? How do you functionalize or operationalize consent? That's going to be for another day to discuss. But these are both required to really manage this sensitive data in accordance with these rules. I just want to be clear that this effort has been coordinated with other industry efforts focusing on this. I co-chair the Privacy and Consent Work Group at Sequoia Project with Devin McGraw, focusing on looking at gaps in privacy and consent management and methods to address those and supporting pilots. The Shift Equitable Interoperability group has a terminology work group that's going to be looking at these value sets, defining them, and defining stewards. So a lot of people working in this space today and a lot of good work going forward. So with that, I'm going to hand it over to Nicole Sweeney from CRISP in Maryland, who's been deeply involved and remains involved in bringing live this SB 786 work. Nicole?
Great. Thank you so much, Stephen. Just a quick check. Can everybody hear me? Actually, you can't answer that, can you? Only Stephen can. Thank you, Stephen, for the thumbs up. Forgot how webinars work sometimes. Well, it's so good to have you all here. This is a critical effort, and many thanks to the folks at Health Gorilla for putting this on and inviting us. For those of you who don't know me, my name is Nicole Sweeney. I am the General Counsel and Chief Privacy Officer for CRISP Shared Services. And also have the same role for CRISP Maryland and CRISP DC, which are the designated health information exchanges for Maryland and DC, respectively. So I have been able to see firsthand over the last year and a half how the laws and regulations that Stephen discussed at the beginning of this call have impacted that interstate data sharing and the concerns of folks at various state levels. So if you go on to the next slide. Right after the Dobbs decision in the 2023 legislative session within Maryland, Maryland was the first state in the country to adopt legislation that was in response to Dobbs to say, we know that healthcare information is shared across the country, and we want to make sure that that data is not used for services that were done legally in our state to investigate or prosecute someone in another state. So there were conversations around how that should happen. This predates even the HIPAA proposed rule, let alone the final rule. So Marylanders are really trying to figure out, how do we make this work? And we did not, the Maryland legislature did not want to wait. They really felt it was important to act right away. And since Maryland has a designated health information exchange, that's where a lot of the patient advocates started and started thinking through, how do we do this in a centralized way so that we can take some of the potential burden off of providers to figure out what's going on or what needs to be redacted, and make it in a centralized place or at certain endpoints that could be redacted before it goes out of the state of Maryland. So with that in mind, what the legislature proposed was that HIEs, who in the state of Maryland include EHRs and EMRs, so there are 16, including CRISP, registered HIEs within the state of Maryland, that HIEs would be the ones that would have to stop the codes before they go somewhere else. So unlike what you'll hear about in a few minutes with California, where it's sort of the it starts with sort of the provider thinking through what can be shared. The providers can share whatever information they want, and then the HIEs have to redact certain information or redact the record in general if certain things appear. So the way that this legislation was originally drafted, it included language similar to the California and now the proposed um, or excuse me, the finalized HIPAA rule, with just sort of generalized reproductive information. And we did some education about that within Maryland and said, that is a great way to proceed if you're thinking about it from the beginning or after perspective when you're trying to when you're giving it to up to the discretion of the provider, working with the patient to figure out what needs to be redacted. As an HIE, in the context of information blocking, which we don't really have time to go through in this session, but I will just leave that as a teaser for anyone that's interested, with a general sort of category like reproductive health or sensitive health records, we're probably going to get more redaction than what is required, and that could hurt patients as well, and was really concerned for providers and from an interoperability perspective in general, making sure that we have the data where it needs to be when it needs to be there. So instead, the legislature decided to go. Instead of just sort of a general category of reproductive health, they went with a general category of sensitive health services, but defined those sensitive health services as certain code sets that they would specify. So the secretary determines certain code sets. The secretary of the Maryland Department of Health determines certain code sets, and those code sets are pushed out in regulation, and those code sets deal primarily with abortion. And then there is also a commission that has the authority to include other code sets. And the idea here was that um, the state of Maryland didn't want to kind of keep chasing what was sensitive. If new sensitive things came up, if other states started criminalizing other healthcare activities, we didn't want to have to go through another round of legislation. We wanted to be able to do that in a way just through regulation or through a committee process. So there is a commission of which I am the current chair, the current reluctant chair. I'm hoping at some point a clinician will decide to take over this role instead of a lawyer. That can specify other codes beyond what the secretary specifies, including gender affirming codes, which we're working on right now, and other codes that don't deal with just abortion or just elective termination, but rather other code sets as well. So this law took effect in 2023. It's currently in an implementation period. There's a lot of pushback as sort of the first in the country, where folks felt various HIEs and EHRs felt that they weren't fully prepared to implement this with segmenting the data or really tagging the data, as Stephen explained, and then redacting it from the record or redacting the record in general. So there's sort of this long implementation period that started December of last year and will probably go for the next year or so. So, from a technology perspective, and why this effort that we're talking about today is so important, is that in order to do any of what the law requires, we need a set of codes. We need to be told this is the set of codes. These are the things that we want redacted. Again, from an information blocking perspective, as an HIE, we really needed to be told this. This and this alone, so that we did not go too far in one direction or the other. So the secretary has a forthcoming set of codes that was done in-house. There was not this effort that we are currently talking about beforehand. And so we're really grateful that this is going on, because it's very inefficient for every state to have to figure out these codes themselves. So no matter what we do, we need to have code sets. And again, very inefficient for each state or each Department of Health to think through what are the code sets that we need and how do they apply in these situations. And again, we're not going to talk too much about patient consent today, but I do just want to talk about that very briefly because it is vital that when these codes are redacted, if patients choose to share them in the Maryland law, they are allowed to do so. And so there is a consent element to allow patients to affirmatively say that they want these shared. The presumption is that they're not shared unless the patients consent. But again, it's all based on code sets and not only HIEs and providers understanding what codes are going to be within that code set, but also patients for purposes of consent. It's a very brief overview of the Maryland law, but hopefully you understand a little bit more of why those codes are so important. So then on to the next slide. So this is not crisp HIE data as we say in the slide. This is data that Health Gorilla has from Maryland. And what they did was they took the Maryland code set, which is currently in draft form. The final form should be coming out at the end of this month or early next month, and ran it against their data that they have from Maryland. That they received through their information exchange, and said, okay, if we apply the code set here, how many patients does this actually hit in the state of Maryland based on the data that they have? And it's about 0.2%. So again, this is another place where these code sets are incredibly valuable from my perspective, in that if you have a code set to begin with, you can run some analytics to say, all right, if we use all of these codes in this set, how many folks would that impact versus if we use this more targeted set that's just related to elective terminations versus this set. So again, this is just an example. I think one of the things that we wanted to be able to show here today is that this is doable. And by this, I mean taking a data set and running it against the codes and being able to identify those within a record. And so this is just an example again of the Health Gorilla data with the Maryland set, to be able to show that this is possible. And you can even see from a quantitative perspective how many patients' records would be hit with these codes. And with that, I am turning it over to our friends in California.
Thanks, Nicole. Hi, everyone. I'm Lisa Matsubara, and I'm the Chief Legal and Advocacy Officer at Planned Parenthood Affiliates of California. I think next slide. So just a little bit about my organization. My organization is the statewide public policy and advocacy organization. We work on behalf of the 7 Planned Parenthood affiliates that operate over 100 health centers throughout the state. And I'm just gonna back up a little, and if we can move to the next slide, to provide a little bit of context behind some of the efforts here. And I know Dr. Lane referred to it a little bit, but I did want folks to see this map and get a little bit of context leading up to AB 352. So on the left is a map from Guttmacher. It really indicates the spectrum of laws regarding abortion. Currently, about 21 states ban some or all abortions. And since the Supreme Court overturned Roe, information that was normally part of the patient's record can now be used for criminalization of receiving or assisting or providing certain kinds of medical services like abortion. We're also seeing it in gender affirming care in some states. And this causes significant privacy and security concerns for patients as people travel out of their home states to get care in other states. So, as was the case before the court decision, abortion bans and restrictions, their main purpose is to really cause confusion, not just for patients, but also for providers on how to comply. And really what we started seeing was that there were providers that were hearing from their patients that traveled to states like California and other states that still had access to abortion, who were going back to their home states and going to their primary care physician or the emergency room for things that were unrelated to the service that they got in California or any of the other states. and finding out that their doctors there could see and had access to all of their records of potentially getting an abortion in an access state. This was very concerning. Patients were very upset about this. And I think, you know, for purposes of what the differences in laws are, really put patients at risk for prosecution, for criminalization. And, you know, another note too, I don't really want to get too far into the weeds in terms of minor consent, but, you know, we actually have very robust minor consent laws here in California. Those are very different than the consent laws in other states. And so there are risks of sending folks back where consent laws and other laws in those states that they are from are really putting those patients at risk. So I also wanted to just put into perspective here that even before the fall of Roe, folks that were criminalized for pregnancy outcomes or self-managed abortions, many of them, the data shows that many of them were reported to law enforcement by their healthcare providers. And then I also just wanted to point out the box in the corner here, which is that abortion is actually extremely common. A recent data poll from Guttmacher has shown that 1 in 4 US women will have an abortion by the age of 45. So next slide, please. So that came to AB 352. And honestly, this was not the first efforts. I think individual providers started working with their EHRs to try to find a way to protect the information, really trying to find some solutions to protect information. And this is where we came up with a few barriers. And I do really feel like I want to provide context in terms of, you know, just the way EHRs are set up. Obviously, there's no like national EHR. People are on different systems. But at the same time, you know, we've all worked in a space where we've worked for a long time for health information exchange. We all believe that having more information and having free flow of information that's accurate, data accuracy, and, you know, data sharing is better for patients and patient care. Of course, none of that really contemplated a world in which in certain states, certain kinds of very common healthcare services will be criminalized. And so we had to work within the confines of what was happening at the national level with the information blocking rule, wanted to make sure that if providers did want to protect that data, that they weren't running afoul of the information blocking rule. And in addition, when we started working with individual vendors, we realized that there were no real good solutions. And even if you worked with your EHR vendor to put protections in place, if things went out through a health information exchange, or if you were on an EHR that had a nationwide health information exchange, that data was free flowing across state lines. At the same time, California was going through something called the data exchange framework. We're currently in that process. Unlike Maryland, in California, we do not have a statewide health information exchange. And there is efforts to kind of consolidate and have some sort of standardized process in which information is shared throughout the state. And so those efforts really made it so that we really needed to find some solution that was more universal and not a piecemeal solution that was kind of based by, you know, individual providers and individual instances or individual EHRs vendors. And so we did actually come up with AB 352. As Nicole said, we had a very different approach on this. We did hesitate about having a requirement on providers, but essentially there's 3 things that AB 352 does, and I'm going to actually start in the middle. So the providers in California, starting January 1st, 2024, cannot knowingly share information about abortion-related services outside of California without the patient's authorization. This was an effort to, A, prevent the flow of information out of the state, but also to have a very distinct exception to the information blocking rule that providers could rely on if they chose not to share this information out of state or for their patients. The second one, and then related to that on the left, We wanted to make sure that the providers weren't left holding the bag in trying to comply with the law without any tools to do so. And so there is a provision that relates not to healthcare providers, but to vendors and businesses to develop capabilities, technological capabilities, to be able to segregate and protect this data. And this data is a little bit broader. It also includes gender affirming care and contraception. And that provision goes into effect July 1st, 2024. And then finally, we did want to address the data exchange framework and make sure that abortion-related data was not part of the data exchange framework while we figured out ways to build that capability to protect that information. So those are sort of the three main pieces of 352. I do want to, stress again with Nicole's point about the importance of code sets. I think, there are going to be implementation. I don't want to call them challenges, but I do want to call them like opportunities. Because when we passed this law, we understood that implementation was going to be difficult, that there were technological limitations that people were going to have to work through. And we really wanted to work with folks to be able to implement this in an efficient way. What we didn't want to do was to legislate exactly how to do it, because we knew that there was going to be complications, and defining things very specifically wasn't going to capture all of the data. One of the challenges we had when we were working with individual vendors was that there's just data all over the place. There's, prescription records, there's the patient encounter data, there is consents that are filed. All of those things have to be captured in some way, and we did not want to go down a route of, being very specific. At the same time, we realize that implementation is going to require, sort of efforts at the provider and user level at the EHRs, but also at the data exchange level. And I think that's where the code sets are going to be really, really helpful as a sort of additional layer of protection from information going out through these exchanges. So I will leave it at that. And then the next slide is similar to what Nicole was saying in Maryland. This is Health Gorillas data. I'll kick it over to Dr. Lane to explain this. But here you go.
Yeah, thank you, Lisa, so much. And I'm happy to cover this. This is similar to the slide that Nicole showed. This is looking at the data that's maintained in Health Gorillas' health data platform. In the case of California, obviously many more individuals represented than were in Maryland, 2.7 million individuals. This one is looking across genders, or at all genders, because of the nature of the rule. But again, utilizing the value sets that we're going to be talking about that are now publicly available. When we looked at the Health Gorilla data set, there was 1.1% of the population that had codified data that was captured within the value sets applicable to AB 352. This was recently validated. Our friends at Supporting Communities Health Information Organization, another regional HIE/HIO in California, they ran a preliminary look at their data using the same value sets, and they came up with 1.2%. So I think what this tells you is that even though, as Lisa said, 1 in 4 women will have an abortion by the age of 45 in this country, the codified data is available in these value sets a small proportion of the time. And I'll just take a moment to say that we've looked at this data, all de-identified in a little bit more detail. We've actually looked state by state, and we've compared the prevalence of abortion procedures, that is to say elective pregnancy termination, with spontaneous abortion procedures. And we've seen a tremendous variability across the country. In some states, there are 10 times more miscarriages than there are abortions. And in some states, there are many more times abortions than there are miscarriages codified in the data. So there's clearly variability across the country in clinical practice, clinical coding. But I think that is worth noting. So here again, California data, California code sets, 1.1, 1.2%, depending on whom you ask. So I'm going to turn it back.
Sorry,
Yeah,
can I
go
just
ahead,
add
Lisa.
one thing on sort of that difference between elective and spontaneous abortions? I do want to point out that many of the laws in the banned states do not distinguish between different kinds of abortions or why you're having an abortion. And so, you know, in terms of the code sets, we really do need to capture all of the different ways in which a pregnancy might be terminated. We have seen through what is happening in other banned states that there is no distinction between why somebody might choose to terminate their pregnancy. And in certain cases, even if there is a fetal anomaly, that would be coded as an elective abortion, not a spontaneous abortion. And so I do want to just be really careful about making too many distinctions between sort of the different ways in which a pregnancy is terminated.
And there's a prescient question in the Q&A that we may get to later about how the folks in Maryland might approach things differently, knowing what they know today, and that might be something that would be included there. So let's go on to Dr. Victor Lee, VP of Clinical Informatics from Clinical Architecture, who has provided some of the infrastructure that has supported the value set authoring here.
Great. Thank you, everyone. Hi, my name is Victor Lee. I'm VP of Clinical Informatics. My background is in internal medicine. I was a hospitalist for about a dozen years, but I have the pleasure and the privilege of working as a full-time geek at Clinical Architecture. We're a data quality solutions company. I think we fit pretty squarely, into this discussion from a value set perspective, because that's one thing that myself and my team work on a day-to-day basis. And to kind of tee up a deeper dive into value sets, I just want to share a few best practices for value set authoring as well as maintenance. So if we go to the next slide, I just have one slide to just kind of tee things up for Raymond. And again, 5 best practices, starting with number 1, which is scope. So as we create a value set, we want to be mindful of the scope. What is the inclusion and the exclusion criteria? So kind of tagging on to this recent discussion around what is abortion, and is there a difference between a spontaneous versus an elective abortion? If we were going to create an abortion value set, we need to be very clear on what the scope is. And this is not just relevant to diagnoses and procedures, but also things like medications. If we have a medication value set, we need to be clear on, are we including all dosages and dose forms? Those of you who are knowledgeable in the medication world might know that for a given ingredient, depending on the formulation, the dose form, the dosage, there might be those drugs might be indicated for different conditions. And so we need to be clear on that. If it's a lab, let's say it's a pregnancy test, are we talking about blood, serum, and plasma tests for example, human choriogonadotropin? Are we interested in cord blood? So there are a lot of things available, but that doesn't necessarily mean that they should be in the scope of a value set. So that's number 1. Number 2 is to be mindful of code systems. So I'm not an expert in the legislative and the regulatory landscape, but as we define code sets or value sets, part of what is in the membership of a value set would be codes across potentially multiple code systems. So for example, in the medication world, are we using RxNorm? Are we using NDC codes? They may all be legitimate for a variety of different reasons, but for that use case, what is the expectation for the consumer of these value sets in terms of what code systems are going to be represented? So those are things that need to be kind of agreed upon beforehand. So be mindful of code systems. And number 3 is a conversation around definitions and expansions. And so what that means from an informatics perspective related to value sets is that one way to define a value set is to simply handpick a bunch of codes. But that's inefficient, it's not scalable. And so what we would prefer to do when authoring value sets is to have a rule-based approach. And rules can leverage things like hierarchical relationships, ontological relationships, attributes, and other properties so that we can define rules that say, if these criteria are met, then the resultant terms that meet those criteria may be members of a value set. And so we typically want to take definitions, rule-based definitions, calculate the code system against those definitions, and that will yield an expansion or the membership of a value set. So you can see how that would be a more scalable, efficient way to author and maintain value sets in the long run. And so number 4, this best practice is around recalculation. And it builds on number 3, because if we have rule-based definitions, then as, let's say, medications change over time, new drugs come onto the market, old ones get retired, what we can do is take those same definitions and recalculate them against the latest versions of code systems so that we can efficiently update and maintain value sets over time. So a little bit of thought and preparation into value set authoring can go a long way. And then the last best practice is really around stewardship. It's around lifecycle management. So as we author and maintain and update value sets over time, who's responsible for the lifecycle management? Stephen, you can advance one, with for stewardship. And so how do we define how input is received from the community? What is our update cycle? And all the things around the lifecycle management. So thinking about the stewardship is also very important. And then finally, there's a link at the bottom if you just advance one more time. If you want to learn a little bit more, there's a white paper that kind of addresses these 5 different things in a little bit more detail. And with that, I will turn it over to Raymond.
Thank you, Victor. Let me just insert here. We always get questions on webinars, whether the recording and the slides will be made available. Yes, they will. So you're welcome to take screenshots, but we'll make these available to everybody. Raymond.
Yes, thanks so much, Dr. Lane. And thank you, Victor, for teeing me up. This is the effort in collaboration with Health Gorilla, AHIMA, Planned Parenthood, and CRISP, where we started developing more comprehensive value sets to encompass the language and the data elements and the verbiage and in all of the 3, the Maryland, California, and OCR final rule. On the next slide, you will see, for example, abortion and related services as they were intended in the wording in the legalese. And we have tagged these. You will see California AB, Maryland HB, and OCR HIPAA privacy. These are all related and mentioned in these policies and regulation. From what Dr. Lee was mentioning earlier, we were very cognizant about how these value sets and codes were, and which codes were included. An example of this would be abortion medications, for example. We know that in the practice guidelines, mifepristone and misoprostol are being used, and we're using generics here. But previously, there were also methotrexate injections that were previously used from more than a decade ago. So we know that this exists, and for folks who did, in fact, use methotrexate injections for abortion medications, these were included. Next up, for example, abortion, just wanted to, for the previous one, these are made in combination with the purpose of combining this with other value sets. For example, if abortion, first, second, or third trimester does not exist, you can use the age of gestation value set and codes that represent age of gestation to kind of mix and match so that you can kind of see first trimester abortion, which was kind of abortion induced, and which was managed medically or surgically. So you can mix and match the value sets. On the next slide, you will next see gender affirming care, which is mentioned in the California rule. We added SOGI codes. Again, these are not really specifically for gender affirming care, but this is an important data element, and there are standards from the Office of the National Coordinator for Health IT to standardize the codes for SOGI, sexual orientation, gender identity. You'll see the intersex surgery was included. These are procedures for both female to male and male to female, and also the basic medications on practice guidelines for transfeminine or transmasculine management. On the next slide, you will next see contraception. And this applies for both California and the OCR final rule. We included contraceptive counseling and contraceptive surveillance, as they were mentioned in the rulings. And also, these are all of the contraceptives available as prescription in the United States using the terminology code system called RX norm. Again, these are not in NDC codes, which most people are more familiar with, but the ONC recommends the RX norm as the way to standardize the coding in electronic health records for medications and not just contraceptives. And these are all of the subcategories for contraceptives which have groupers. So please go on VSAC, get the UMLS license so you can access all of these value sets. And I'll show you even more. On the next slide, you will see after contraception, we have infertility, again mentioned for in California and the OCR final rule. All, when you see comma all, that means that's a grouper for all things related to the diagnosis of infertility. Which includes kind of a basic value set for infertility for female medications, including letrozole and clomiphene. On the next slide, I think there's another set that was mentioned, which was they used the term miscarriage management. And this was tricky because there are different ways to manage miscarriages. But for those who want to identify those who have had miscarriage, the values set to be used are for is abortion, comma, spontaneous / miscarriage, in combination again with how it was managed, either through a medical management through mifepristone and misoprostol, or a surgical management using a DNC, for example, or dilatation and curettage. Next slide. For prenatal care, this is the, again, they just mentioned prenatal care. They didn't mention the exact definition or formal definition of prenatal care. So you have to use different value sets to find this in your data and protect them. For example, how do you know if a patient is in the prenatal period and is pregnant? As you know, pregnancy needs to be confirmed by a provider and at all times. If the patient says they're pregnant, you don't believe it, it needs to be tested. And these are all on LOINC, as what Dr. Victor Lee mentioned, is the pregnancy labs and blood, serum, or urine, etc. Next one, if those aren't available, there are surrogate data elements for those. For example, EDD, estimated date of delivery, or last menstrual period, to determine the encounter date in relation to the prenatal period or before delivery. And you will see this across the value sets. You have to really think about the semantics and how you use the value set and what it's used for. An example of this would be encounters that mark the end of the prenatal period, which is a pregnancy that ended in a delivery. May it be an abortion or just a regular live delivery. Those are the ways for you to say that, okay, that's the end of the prenatal care. So these are the codes that kind of help you approximate these timelines to see if the patient's in the prenatal period or postpartum period as well. Next slide. You will see now, I believe, other things mentioned in the OCR final rule. Again, the OCR final didn't have a list of codes, but it did have these specific terms. Again, just a reminder from the top, starting from the top left, emergency contraception is already a value set named contraceptive emergency contraception, POPs, because progestogen only pills are the ones being used for EC. So your Plan B on the shelves are actually a combination of generic drugs in a specific dose strength. Next would be preconception screening and counseling. Unfortunately, there are no specific procedure codes for preconception counseling because those CPT codes are bundled, meaning preconception screening, prenatal care, postpartum care, all have a bundled procedure code, which makes it very difficult to find preconception screening. Although there are Z codes linked to these CPT codes, again, for family planning. These are the Z31 family of codes. But again, Z code use across all states are very, very low. But do in fact check to see if these Z codes exist. On the right column, starting on the top here, pregnancy screening, again, confirmed through pregnancy labs. For prenatal care, those again are using CPT codes, can be generic or not. For miscarriage management, this is again another term for medical or surgical management of miscarriages. And you saw that in the earlier slide. Last but not the least, what is being built right now is the treatment diagnosis sets for preeclampsia, hypertension during pregnancy, GDM or gestational diabetes. Diagnosis value sets are done for all of these. These are going to be pushed to VSAC very soon, which will be accompanied by the treatment sets. Again, these sets are very difficult to create. You really have to make sure that the data elements and the dose strengths and the dose forms are conformant with current society, guidelines, and current evidence published in research. Next slide. For molar and ectopic pregnancy, the diagnosis sets are ready. Treatment is very tricky for these as well, but they are being built out right now. For pregnancy termination, again, the wording here is from the OCR final rule. The pregnancy termination, you can use any abortion of the abortion value sets and protect those. Fertility and infertility diagnosis, those are already published. But there are specific testing for fertility that if you would like to protect, which is currently being built out, such as sperm count, patency of the fallopian tube, and all of that stuff. IVF, again, is very complex. This is in the left bottom column. This is really complex. There are a lot of different balancing and different dose forms for which is related to testing. So this is very tricky, but we'll do our best to really have those codes ready for everyone. And the last column here on the right, the diagnosis for perimenopause, menopause, endometriosis, and adenomyosis. Again, it's very, very comprehensive. This is in really the realm of obstetric care. But these are being built and we are very reviewing it. Last but not least, on the wording there, mammograms, pregnancy-related nutrition services, and postpartum care. We have postpartum. We even have postpartum depression screening and postpartum contraceptive counseling, but we were currently building mammograms and other. By the way, I'm Dr. Raymond Uy. I'm from NAC. I'm the physician informaticist. I forgot to introduce myself. I believe I have one more slide, just making sure. Again, if you have any questions, please feel free to reach out to us. Again, any feedback is very much appreciated. And I think I'll let Dr. Lane give the summary. Again, thank you so much.
Thank you so much, Raymond, and all of the presenters so far. Really appreciate all of this. So just to try to pull this all together here before we go to Q&A, we've been focused on value sets. These value sets play a key role in supporting compliance with these regulations. They're not, the entire answer. They have to be implemented within a compliance program and will be used differently by different stakeholders. Maryland, as we've said, has a code-based regulation for better or for worse with a very specified value set, which is still being finalized, but that will make value set-based implementation and compliance quite within reach. In California, the regulation specifies clinical care domains. We've developed and posted value sets for those. We've tested them, they work. And I think that will make things easier in California. I know we've got a number of folks on here from EHR developers, from others working in the health IT space, and the whole goal here was to make these value sets available in the public domain so that they can be put to use in various implementations. The HIPAA rule, as Raymond was just covering, is much more complex, has a much broader scope of data. Those value sets are being built out now, since that rule's only been out for a couple of weeks. And of course, because it is a purpose-based restriction, compliance will require much more than the use of value sets and data segmentation. But as I said, the sets are there. For California, Maryland's set is going to be posted once they've finalized their rule. These are open source. They will be maintained and expanded over time. Thank you very much to NAC for their willingness to commit to doing this and being the stewards of these value sets. These are not maintained by the government. These probably should not be built and maintained by individual organizations, but you're always welcome to do that. This is meant to be a gift to the industry so that we can do this in a thoughtful way together. And again, these value sets are foundational tools to support compliance for all of us who are regulated by these rules. So with that, we're going to go into Q&A. We've had a number of great questions posted. We're going to try to take advantage here of the time that we have. So the first question was, does data actually have to be tagged at all times, or is it just important that sensitive data can be recognized? I'm going to actually take a stab at this myself. It's up to you, I mean, depending on your health IT system, your workflows, your use cases, you might be able to look at this data in real time, use reporting, et cetera. You might feel that you need to tag the data so that that metadata is maintained and can be accessed. Part of this will have to do with the efficiency of computing that you've developed. So I don't think that there's a single answer to this. I don't know, Victor, if you wanted to take a stab at this, or Raymond, or anybody.
Yeah, I do have a comment. Thanks, Stephen. I think the purpose of having value sets is, at least as we discussed, the scope of this discussion was around structured data. So if you have structured data, and whether you natively represent it as things that are, for example, recommended by the United States Core Data for Interoperability, like RxNorm, LOINC, SNOMED, CT, ICD-10, et cetera, whether you natively represent them in that manner or you have local codes, the fact that they're structured means that you can normalize your local codes to the standards or the code systems that are used, for example, in the value sets that Raymond said was going to be posted to VSAC. So in that context, you don't need to tag them because the fact that they're structured allows for a systematic normalization. So that would be accomplished through a mapping, for example. That is typically what we see our clients do. Of course, there's a whole separate conversation, and there was a Q&A, I think it was by John Halvey, around the unstructured data, and there's another conversation around that. And I think Raymond provided a preliminary answer in the Q&A. So
we have a
And
slide.
we will try to capture the Q&A and post that along with the materials from the webinar for those who are interested in. Sorry, Raymond?
Yes, we have a slide for those questions, I believe. Thanks, Victor.
Okay. All right. The next one was, if you were to rewrite the Maryland law, knowing what you know now, what would you recommend be changed?
Phew. I think it's a great law for the short amount of time that wanted to have. I think if we had like 3 to 5 years, which we don't, right? But if now that we have that in place, if we have 3 to 5 years and we kind of go back and say, okay, what do we do now that we have this other thing in place in the meantime? I think there's 2 options that I see. One is, and I'm biased, right? I represent the health data utility for Maryland. What we're seeing right now is 16 different endpoints doing the same things, right? Because they're kind of they're segmenting it they're doing the same segmentation at different endpoints. That's not really the most efficient way to do things. So I do think that in the future, having a consent management utility, whether that is a part of the health data utility or something else, where there's one centralized place where that segmentation and tagging and all that kind of stuff can be done before it goes out, is extremely efficient, and you can tag on patient consent. So we only have 2 minutes left, but I think that's one thing. I think the other thing is the Maryland law, sometimes the way that I think about it is like if you had a load of whites and you got a red sock stuck in it, and then your all of your clothes turned pink, and then this law is kind of the bleach to make them white rather than just taking the sock out from the beginning, that red sock out from the beginning. So I do think that if you don't have that consent management utility, the other potential option is similar to the California law, where you say, okay, from the beginning, how do we have something that makes sure that the data doesn't get in there to begin with? And that kind of solves some of the free text questions that we had coming up. So I do think the HIE is a great option. I think to make it really standardized and efficient, you need it in one place. And in the absence of that, it might be more efficient to do it at the provider level.
Great. And in the 1 minute remaining, there's a question here. Providers document the history and physical section. I think this was the one that John was credited with and has already been answered. So rather than going over, I'm going to thank all of you for your attendance. We had well over 100 people this webinar, demonstrating the real interest in this topic. More work is being done. As we said earlier, a number of organizations are involved. The goal is to try to move this forward as an industry, as opposed to making every organization do this work themselves. And again, all of these materials will be posted along with the questions and answers. And thank you for your time and attendance today.